So, with this, I am going to few words about the hypertension. Because of hypertension is a vast subject, I cannot cover within the short time. I am going to finish in small times. I am going to discuss about some controversies only. Regarding the consensus, our senior physician, Dr. Loganathan, Dr. Sebastian, Dr. S.R. Subramaniam can answer this consensus. What is the controversy regarding hypertension? From the beginning, there is a. Before that, what is the definition of hypertension? So, at present, the definition of the hypertension includes the BP, systolic pressure more than 140, diastolic more than 90, the age above 19 years to 60 years. So, prior that in mid-1950s, the definition of the hypertension is varied. I think Dr. Loganathan sir knows about. So, the systolic BP more than 160, diastolic more than 90 is a definition of the hypertension. Those days they followed the curriculums. But recently there are so many changes happened. After the NICE 2011, they classified somewhere away. And 2013, the European societies presented the separate classification of the hypertension. And 2014, JNCA guidelines, they have overlooked the JNCA 7, they have given the new definitions. But this definition was not accepted by the Americans. Those days, and also the National Heart Lung Institute, they put a separate president of the organizers for the JNC 8, but they are not concerned with that. So they rejected, they developed the new hypertension policies in the American Society associated with IS, International Society of the Hypertension. So with this, regarding the Indian scenario, the prevalence in India is at present 29.8%. I don't know whether it's the correct record and everything, because all senior physicians, because the hypertension is a topic of physicians. So hypertension is a more, the hypertension, the more treated by physicians than cardiologists. We are seeing only less number of cases. In our practice, nearly 10 to 20% of the hypertension we are coming across. But whereas physicians, there are more than 80% of cases of hypertension that are taking the nose well. So I don't know this. Because of 1950s, they are given some statistics in India along with the AIMS and Madras that put the instant wise. On those days, in rural and urbans is varied. It is almost more than the triple that time now is raised. So still the rural is less incident than the urban areas regarding the incidents. The prevalence, the urban is 33.8%, the rural 27.6%. Among this, the BP under control is 20% on the urbans and 10% in the rural areas. Almost nearly more than the 60% of the people is not under proper control. That means, again, the treating, whether the treating physician is wrong or the awareness is less, we don't know. That is the main controversy. Still, beginning the 1950 onwards, the same scenario is going on. Still, one of the leading cause of death is hypertension-associated disease. One of the non-communicable disease, hypertension-associated complication is one of the leading cause of death in worldwide. First of all, stroke, second coronary artery disease, and hypertension, end organ damages. The third most is leading is a chronic disease. So, everybody knows about the history and blood pressure measurement. First, they started as a non-invasive BP measurement is a non-invasive procedure. First started 1733. Because of this very tough, we cannot follow that time. So another revolution changed. The sedentary also is one of the non-invasive, but we can't do that all the times. So another eureka that revolution after the invention of the spigometer It's one of the very simplest procedure among our health workers, not only the physicians, it's the very simplest procedure among the health workers. So, first of all, the guidelines, most of them, because of the hypertension incidence and statistics, because of the false measurement of the BP, so the pseudo hypertension is so common, and that in our rural and urban setup also nowadays. So for that the new guidelines, I don't know how many of them following these guidelines, but this in everywhere is prescribed, but we cannot follow all the times. Dr. Lona, sir, please. Regarding this controversial, Dr. Sanjeev sir, you can. How many of them we are following these guidelines? We cannot follow these guidelines because of the patient. If you are following the guidelines, patient will be abstinent. No patient will wait at present more than 30 minutes for outside our business. Sir, I am very hurry, sir. First time is over, sir. So this guidelines is Dr. Subramanian sir can answer this.
The consulting room cannot make the patient wait for every patient for 30 minutes.
But these guidelines, 20 years back, Dr. Lona sir, your experience, we can follow 20 years back, the patient can wait. But this scenario is now changed now.
Then I don't think the patient was willing to wait.
So this is whatever the guidelines says. That is why the pseudo hypertension is so common in our setup. This is a controversial, still not only controversial, our practice also like that. So this is a main difference, the key technique, main difference. We will go for the false things. The rest more than 5 minutes, there is a main difference. And the seated back supported, and also the how the difference we know. Also the cup size also important. Also the way of putting the cups, the bladder in the center of the artery will give the pulse measurement. So this is the ideal guidelines that followed given the. Another is ambulatory blood pressure monitoring. These are not only the newer technologies, new award technologies. How is it useful? Indication is to eliminate the borderline hypertension and white coat hypertension. White coat hypertension is the prevalence is among 35 to 45%. And the isolated systolic hypertension, nocturnal blood pressure is one of the important things. Most of them we are missing the nocturnal blood pressure, so common in diabetic and kidney and chronic kidney disease populations. This is one of the commonest mortality. Another is resistant hypertension. What is resistant hypertension? Definition, newer definition. Subramanian sir. Here this is a controversy. Please don't mistake me. Still, even though it's one of the common disease in the public, it is commonly treated disease, still is not under control because of the reason, not only for us, still it's controversial.
Even with the maximum therapeutic dose of 3 or more drugs with the diabetes, it's not controlled by drugs. It's called resistant hypertension.
Yes, sir. This resistant hypertension is our routine services we cannot manage. So only the help of ambulatory blood pressure monitoring we can help it. Another is hypertension of the pregnancy. Hypotensive symptoms can be assessed by ambulatory blood pressure monitoring. So it's having also certain limitations, time consuming and also cost consuming. So the most of them not agreed the simple measurement for the 24 hours things. So that awareness is still less in our country. So another is guidelines, similarities and differences. These are 3 guidelines. The NICE criteria 2011 is now most of them not following. The JNC 8 and European Society of Hypertension and American Society of Hypertension with the International Society of Hypertension only little bit vary. So regarding the treatment, how many of them using the beta blocker is the first line of therapy? How many of them using the diuretics of the first line of therapy? How many of them choosing the initial two drug reason first itself? That is still controversial. So this is differs, the individual experience is varying. Still, whatever the guidelines given the things, the individual experience is different regarding the treatment. So Indian hypertension guidelines, still we are using the same way of the British guidelines. There is nearly more than the 8 countries they have separate guidelines. So we are having a similarity of the British Hypertension Society guidelines, A, B, C, D regime. That's what our past teachers in 30 years, 40 years back, what they teach is now the following. That what the beta blockers that recently replaced, now the selective beta blockers, the old atrial and everything is outmoded. So the additional advantage of not only the beta, the alpha inhibiting is now they using, now the nebivolol and bisoprolol is replacing the old, but old trials all everything is based on the atenolol only. The drawback of atenolol is not going to effective on the central aortic pressure. So one of the important criteria to monitoring the mortality is the controlling hypertension, central aortic pressure. Then, what is the fixed dose combination? Polypus. The combination therapy is gaining ground since a majority of the patients requiring more than 2 drugs of the sustained or effective BP control. The Indian guidelines use the fixed dose formulations should be considered to improve the compliance. So everybody knows this. Still beta blocker. The life study is more effective. The losartan is more effective than atenolol in reducing the cardiovascular morbidity because already I explained to you this there is no effective on the central aortic pressure. The Ascot alpha trial also based on atenolol, the proven the lesser effect. So newer beta blocking, vasodilating beta blockers do not share some of the limitations of the traditional beta blockers like atenolol. So the Kim et al. They described the newer third generation vasodilating beta blocker is the first line option for the hypertension. The recent trials, so the sprint trial that mainly based on the non-diabetic populations, this outcome, the intensive treatment of have 28% lower the primary outcome. So I am not going to details about it because of so short time. So implication on our practice. Another thing is POP3 VP trial. This is also having the, because of these drugs, most of them, how many of them using this, I don't know. So, the main, given the attention for the proper BP measurements. So, in special cases, hypertension, diabetes, and CKD is also still varied. How many of them agreed the JNC 8 criteria based on the diabetes and CKD? Still, this individuality is varying. I am not voting for the central, what the guidance says. What according to the Accord BP trial, this is also type 2 DM targeting systolic BP less than 120 as compared with less than 140 did not reduce the rate of composite outcome of the fatal and non-fatal major cardiovascular events. Our BP goal, JNC criteria, this is, so the age less than 60, 140, 90, the more than 60, 150, 90. The patient with the diabetes, the goal is less than 140, 90. Diabetic with albuminuria, proteinuria more than 300, the less than 130. So the CKD patients, probably the 140, 90. Also the gross proteinuria, 130, 90 is accepted goal. This is another Indian guidelines. So they generally accepted the aim of less than 130/80 in gross heart area, more than 300 for 24 hours. Another trial is MAPROC trial is showing the 48 ambulatory BP measurement. Another is the dosing of the hypertension test, whether its ideal dose is morning or evening. So it still varies the individuality. The trial is going, trial is going to finish at 2020 Hygienia trial and time trial. So the conclusion, the hypertension remains a condition of public health importance in India, not only India, throughout the world. The methodology to measure the accurate BP should be given the due importance. The ambulatory BP measurement is useful for tool in certain conditions. Although the recent trials have proved useful informing the lowering the BP, further usual goals of BP should be followed. BP goal can be lowered further in some special populations like diabetic and chronic kidney disease and pregnant women. The choice of drugs for controlling BP should be individualized. Till more data emerge, evening dosing of the antihypertensive can be advised. Some data shows evening drugs is ideal for reducing the cardiovascular mortality, but there is still the ongoing is going on. It will be finished 2020, I think. Thank you, sir.